Good afternoon. My name is Brittany Copeland here at the Southeast AIDS Training and Education Center, and I would like to introduce Dr. Wall. He is going to speak on resistance. Dr. Wall is an associate professor of medicine in the Division of Infectious Diseases at the University of North Carolina. He is also the site leader of the UNC AIDS Clinical Trials Unit at Chapel Hill, and he co-directs the HIV services for the North Carolina Department of Correction. And in 2011, Dr. Wall also became the director of the North Carolina AIDS Education and Training Center. So now I'm going to turn it over to you, Dr. Wall. Thank you.
What I'm going to talk about is switching therapy after virologic failure. And I qualify this because you don't always switch. In fact, there's some good data that show if you take someone who is on a regimen that's a pretty decent regimen, let's say it's a boosted PI regimen, and they're not taking it the way that they should, and with boosted PIs, it's pretty unusual to get resistance. So you get a genotype, and the genotype shows pretty much nothing major, maybe just some old stuff, nothing in the PI class. Just yelling at them, shaking them really hard, counseling them in a evidence-based manner, any of the above that would work to get them to take their medicines. If they do, they can get undetectable. And you didn't really have to switch them, you just had to have them take their medicines. And again, the caveat there is they really haven't accumulated lots of resistance. They're on medicines that are pretty much bulletproof to resistance, and they're just not taking it. That's the issue. Restarting that kind of regimen, people will do well. So in your clinics, you'll see someone who comes in, they haven't been seen for 2 years, they were on boosted atazanavir plus Truvada, you get a genotype, it really doesn't show hardly anything. Starting them back on that regimen makes a lot of sense, even though they have lots of virus and they were on that before. If they start it and their viral load doesn't drop down the way it should, if you are able to detect resistance, because after they start it, it might uncover some resistant virus, then you might want to switch. But in many cases, just starting back the regimen they were supposed to be on but weren't taking appropriately or were taking suboptimally could work. But let's talk about when you do have to switch medicine, because that does happen too. And here's the quote, that you all can see. All happy families are alike, and each unhappy family is unhappy in its own way. You can say resistance instead of happy or unhappy, and you can say patient instead of family. So people who are suppressed, they're all alike. They take their medicines, their virus is suppressed. The medicines are working against their virus. But patients who experience virologic failure, they could pop up with virologic failure in a whole bunch of different ways with a whole bunch of different resistance. So let's talk about that. I'm going to try to get my slides to go. I think I have to click on it and then, okay. So in the treatment guidelines, which should be sort of like your Bible, the Department of Health and Human Service guidelines are really well thought out. I'm on the panel. We argue about like consonants rather than just like term. Everything is gone over. Every single little word, there's a debate about oftentimes. So I think it's a really good document to have on hand. It's a huge document because most of it's references and some discussion, but the tables are really good and the discussion's there to explain things. So it gets updated very frequently. So this is a living document. I wouldn't print it out. What I would do is have a link to the document and then update that link every once in a while and look at what's gone on. But here's a version that's fairly recent. And here's the recommendations regarding the management of the treatment experienced patient. And the idea here is that, and I'm emphasizing some of the things that are really important, a new regimen should include 2, preferably 3, but 2 is acceptable if it's the right 2, fully active agents against the virus that person has or that you think they have. And a fully active agent is one that's predicted to work based upon resistance testing or a novel drug action. So an integrase would work in someone who's never been on integrase before because transmitted resistance of integrase is just very, very, very rare right now. So just some basic concepts are you want to get people undetectable, you want to use at least 2, maybe 3 drugs if you can, and that's really important. So what are some studies that we can look at that help us see what we can do? These are studies of failing patients. These are patients whose virus is not under control with their regimen, and they have 2 arms in most of the cases, and the name of the trial is on the left. then there's the experimental arm and the control arm. In the experimental arm, it's dolutegravir plus background therapy, so whatever you think is going to work. So the site was allowed to choose what they thought would work in this case, probably a boosted PI, plus maybe some nucleosides, maybe a non-nuc, plus dolutegravir. The same thing versus raltegravir. And the outcome when it's a check means it's favorable for the experimental arm. In another study called the second-line study, lopinavir ritonavir plus raltegravir was given alone, and this is compared to 2 nucleosides and lopinavir ritonavir. These were not people who were deep salvage. These are not patients who had accumulated lots and lots of resistance. EARNEST is another study that's sort of the same sort of way, and we'll go over it. Same sort of thing, integrase and a boosted PI versus integrase and a boosted PI, and then switching just to the boosted PI alone, monotherapy. Again, these are not deep salvage patients compared to more comparable therapy with a boosted PI and 2 nucleosides. So remember, 2 nucleosides and a boosted PI, that's pretty standard stuff. The stuff we're looking at on the left side are things that are a little bit avant-garde or different because we're dealing with patients who are failing their therapy. There was another recent study called the OPTION study by the AIDS Clinical Trials Group. This is the big federal network. And that was whether or not to use nucleosides or not with background therapy. Patient comes in, you get the genotype, you decide what you want to put them on. If these were patients who were resistant largely to nucleosides, some of us kept the nucleosides on, some of us didn't. This study looked at whether or not the nucleosides were useful or not, and we'll go over that. So these are just 4 recent studies that I think can help us. There's also been another study, before I go into those, of a treatment-naive group. So these are patients who've not been on therapy ever before. They don't have resistance, but I think it's instructive because it shows us this concept of 2 drugs working. So believe it or not, these folks were randomized to either get lopinavir ritonavir, a boosted PI we do not use anymore, hardly ever. That's because there's more toxicity with it. It's 4 pills. We have better therapies now, generally. But I will say this is a drug that's very powerful. And so it may not be as well tolerated as some of the drugs we have now, but it is pretty powerful, and we would be careful about extrapolating one boosted PI like this to another. But I want to point that out. But lopinavir ritonavir was used here with just 3 TC. People would say that's crazy, but it isn't. And when you look at the results of the study, you'll be really amazed, because when you compare that to 2 nucleosides, so like 3 TC or FTC, plus a more standard nucleoside, so like tenofovir FTC or abacavir 3 TC, things that people use commonly. And you can see in this study, because it's a little old, they used even AZT 3 TC. Most of it, the rest of it was Truvada. So you had Combivir, Truvada, and what we call Epsicom now. But that was along with the lopinavir ritonavir as a standard initial therapy versus lopinavir ritonavir and 3 TC. And remarkably, it worked. The 2-drug therapy worked. So if you have 2 drugs, it can work just as good as 3 drugs, just has to be the right 2 drugs in the right patient with the right virus. So I'm not going to go over every study one by one, but I'm going to just tell you there is hope for people with failure. There's hope for people like in this study, the second-line study, where these are patients who had failed 2 nukes and an NNRTI. So this could be like your atripla failures. And they randomized them to 2 different strategies, and both of them worked really well. You could see that right here. At the end of 48 weeks, both arms had about 80% undetectable. Now, the integrase inhibitors, and this is something I pointed out to Jenna the other day, integrase inhibitors will drop your viral load quicker than anything else. But everything catches up as long as it's an equivalent regimen. So if you want to get your viral load down very, very quickly, an integrase inhibitor will do that. We don't know the clinical significance of that, but that's why there's a big difference between the 2, but then they catch up by week 48. I'm not going to go over that. Here's another study I mentioned before that even just monotherapy with lopinavir ritonavir has been tried, and other boosted PIs. Let me tell you about how that worked out here, because in like other studies, it's not a happy story. These are patients who, again, were failing. They had previous failure due to non-adherence or other issues. They had received NNRTI therapy, so something like efavirenz, right? And they were randomized to lopinavir ritonavir plus 2 to 3 nukes, pretty standard. Funky lopinavir ritonavir plus an integrase. Don't use that a whole lot. It's a pretty novel therapy. Or that, and then just let's switch to monotherapy with the boosted PI. And here's what you see is if you look at patients who had all the way out to 96 weeks of data. The 2 boosted PI regimens that had something else along with it did well, but the PI monotherapy did not do well. So we don't use PI monotherapy hardly at all. And so 1 drug didn't work, but 2 drugs did. That's the bottom line. Dolutegravir is another choice. It works really well, and on top of background therapy, worked just as well, if not a little better, than raltegravir in this study. So again, another option you're going to hear about and something we're going to talk about. The last study I'm going to talk about is that option study, Are NRTIs Necessary? This is a group of patients that were failing HIV therapy, and they had resistance. So these are patients who had pretty wide treatment experience. We had a committee decide what to treat people with. They had to have at least 2 drugs that were thought to be active, and they were randomized to include NRTIs or not. And if you omitted the NRTIs, it didn't seem to make much difference. If you included them, it didn't make much difference. Things were very similar. So NRTIs were not necessary. They added cost and possibly toxicity if at least 2 active drugs were already in the regimen. So overall, there are reasons to consider ART switches in patients, especially those who are failing. Maintaining viral suppression takes at least 2 active agents. You have to carefully consider what those active agents are going to be based upon ART history, based upon resistance, based upon can you get the medication paid for, will the patient take it, does it interact with their other medicines, that kind of thing. But the good news is more and more it's getting easier rather than harder to treat initial therapy failure and even some of the deeper salvage given the tools that we have right now. But adherence continues to be the main driver, and when people come to me with patients who have really bad resistance or continued failure, it comes down to adherence. And if you're not going to take the drugs, it doesn't matter what you choose because they're not going to take the drugs that you're going to give them that are going to work against their virus. So that's not going to be the issue. It's going to be adherence. And that's a whole nother session that I'm sure if you haven't had already, you will.